I got lucky. Dude just clipped me.
Let's see, you got a headache?
Not really.
Whoa, what a nice wound. Dramatic hospital drop-offs, distracting injuries versus life-threatening ones, and other hard truths medical staff face during mass casualty incidences. In honor of the new season coming out, today we're getting another dose of the medical chaos that I deal with on a daily basis as an emergency room doctor. From the pit, let's dive right in.
There is an active shooter at Pitt Fest.
Whoa.
As the nearest trauma center, we are going to be getting the majority of the victims. We are instituting hospital-wide emergency protocols. We need to move every patient out of here. They either go home, they go upstairs, or they go to family medicine.
This actually does happen. Hospitals are trauma centers or not trauma centers. There's different levels depending on what the hospital can handle. In many cities, there are a lot of different hospitals, so they try to share the amount of patients so you don't overburden the same hospital system.
Our ambulance bay is now our triage. EMS will be overwhelmed. Most will probably arrive by car, several victims per vehicle. Triage will decide who goes where depending on their injury.
Triaging who needs to actually be seen quickly now versus who can wait.
We need to keep everybody out in the open so we can keep an eye on everything.
An ER doctor, as well as staff that work in the emergency department, being able to manage things and keep things in your head, aware, all going on, managing it and not getting it all jumbled up. In this scenario is where that skill thrives.
Okay, triage is going to assess and assign every patient to a specific zone with the colored slap band.
Red is crucial but salvageable, or the person that you want to take care of first. Then you have yellow, intermediate, warning zone kind of thing, right? Slow down. And then green, go, they're doing okay. And then typically black, or the other component is they are near death or have died.
Patient who comes in with a red slap band goes to the red zone, which is the trauma rooms with overflow out here. These are the most critical patients who will die without immediate attention.
Good utilization here instead of trying to tag somebody and put it on them a slap band. Great idea. Quick, easy.
We have 5 minutes to try and stabilize the reds. After that, it's OR, ICU, or morgue.
It sounds really morbid. You can't just spend all your time on one patient because you have 20 other patients that need that exact same care. So you're trying to save as many people's lives as possible in the shortest period of time with the amount of resources, again, that you have.
We're a MASH unit now. There's no charting, no electronic medical records, no board.
How do we document treatment?
Oh, you'll all get Sharpies, and every patient has a risk chart to document treatment and procedure.
Similar system when actually the computers go down. We actually go back to paper orders, paper charting, and it becomes a mess, but then it all gets dealt with later when there's more time.
No ultrasound, no x-rays, no CT, no labs.
Blood work, imaging, everything. You can't order it. Like you order it and wait for it. No, you just have to treat as best you can, clinical medicine, save people's lives. You're trying to stabilize them to be saved.
I got 4 shooting victims.
What's your name?
So people will just show up to the emergency department, and this actually just happens anyway. You'll have trauma cases actually show up to a non-trauma hospital. You want to help them, you'll assess them, but by law you have to do medical screening exams, and then you need to stabilize any life-threatening issues.
Show me. Right chest, strong radial, pink.
Wound to the chest, breathing, but good pulses. If we don't assess this within an hour or address the issue, could he have a collapsed lung, compressing the heart down, losing pulses and going into cardiac arrest? Yes, needs immediate care, but has a second.
What's your name?
I'm Sylvia. This is my son, Omar.
Omar, can you open your eyes for me?
He's deaf.
Omar is deaf, making things much more difficult, and he has a gunshot wound, it looks like, to the right chest. He made him a red, potentially because he may not be able to hear what's going on, or people may not be able to reassess him, so get him taken care of quickly and make sure it doesn't get worse.
What happened to your leg?
I got hit by a car when we were wheeling.
Okay, we'll see you inside too.
Yellow, extremity injury, but stable, needs to be assessed, but has time to go to the yellow section.
Document the tourniquet time. Mark the arm. Mark the chart. Let it down briefly once an hour, okay?
Extremity injury, has a tourniquet on. I've told this many, many times. We'll use the CAT tourniquets, the combat application tourniquet, and always document the time. Tourniquet hurts like hell. That could be the reason why she's having discomfort, but also could be just from the injury itself.
Morphine, repeat if needed.
Morphine we use as a pain medication, but you have to be careful. Morphine causes a little bit of a histamine reaction, not an allergic reaction, but then will actually cause your blood pressure to drop a little bit. So in the setting of where somebody might have low blood pressure and you're giving morphine, you have to be aware that you could drop their pressure. Why are they using an ultrasound on the top of a foot? They're looking for the dorsalis pedis pulse. The reason why we're checking it is to make sure that there's not significant swelling, the blood vessel didn't get injured, and that there's continued good flow in that area, so you don't have to worry about a vascular injury.
Oh, looks like closed tib fib fractures.
Closed tib fib fracture. The tibia and the fibula are the main bones from the knee to the ankle. The tibia is the main big one, that's the weight supporting bone, and then the fibula actually is along for the ride for more structural support but not weight bearing. Closed meaning that it didn't pop through the skin, but there's a fracture. So you're assuming that based on the injury.
Great flow with the butterfly.
Great flow with the butterfly. Think butterfly needle, like, oh, they put a needle in and it's like flowing blood out. No, the device that they're using to probably a type of ultrasound is a butterfly because it connects into the phone. It's a branding thing.
She needs x-rays, AP and lateral.
Well, radiologist's gonna be closed for hours. Put her in a long cam boot and pain meds. We're just gonna make you comfortable.
You can't actually confirm, but they're gonna stabilize it with a boot. It's faster than putting somebody in a splint, but a long cam boot because it needs to go all the way up to the knee.
Okay, pressure dressing on this.
Okay. But what if he dropped a lung?
Then I'll throw in a pigtail.
He got shot in the arm, but he's intubated, concerned about drop lung. Bullets ricochet, bullets travel, and if you're not having a through and through injury where you have an entry point and an exit point and you only have one hole, it might have changed directions and went into a different area of the body.
Unresponsive, had a weak femoral, lost it.
Most of the time we're doing CPR moving while on the side of an individual, but it could be easier just to be on top of the individual. If you lost pulses and had chest trauma and you're in this situation, you're going to do a thoracotomy.
This is Grayson Cooper, 68. Bullet grazed his scalp.
I got lucky. Dude just clipped me.
You got a headache?
Not really.
Whoa, what a nice wound. Lucky, grazed it. You don't have the ability to get an image, but the patient is clinically moving, talking, aware. Here you have a pretty good scalp wound. Exploring the wound a little bit, wash it out, you staple it shut, and move on.
Sylvia? Whitaker? I
Oh.
lost her radial pulse.
From a broken leg?
Well, what did we miss?
Loss pulse from a lower extremity injury, could be a fat embolism, could be a clot embolism, something going to the lungs causing a blockage, not allowing gas exchange, and then heart will cease to function.
I don't know, heart attack, another injury from the car crash?
That's for pulses.
It has an E-fast mode.
Diagnosis made. Blood in Morrison's liver laceration.
Ah, fast exam or an E-fast exam. So you're doing a focused assessment in trauma. Looking at the heart, you're looking at Morrison's pouch, which is the right upper quadrant of the abdomen, looking for free fluid that sits between the liver and the kidney that you'd be able to see. Then you'd actually do it on the other side, looking at the area around your spleen, and then around the bladder where sometimes dependent fluid can just pool.
This.
Unresponsive, even to pain. No GSW, strong pulse, but tachycardic and diaphoretic. Looking for internal hemorrhage.
You're tachycardic, so you're probably in early stages of hypovolemic shock, aka blood loss. That's why he's doing a quick fast exam to see if there's any internal bleeding where the blood would be pooling.
Fast negative.
Help me, roller.
Look, glucose monitor. She's diabetic and probably hypoglycemic.
So check a blood sugar.
Fast is negative, glucose monitor, they're diabetic, they don't know what the blood sugar might be, so it could be super low and she's having a adrenaline response to it.
No time for that.
Still could be head trauma at 50K. You're making it worse.
My spidey sense is telling me she took her morning insulin, but she skipped lunch. She's in a coma from low blood sugar.
Yep, good idea. Either hypoglycemic, so low blood sugar, versus hyperglycemic, which then would lead to something called diabetic ketoacidosis.
Will you look at that?
When we give an amp of D50, it's 25 grams of sugar, but the 50 just means it's 50% sugar basically. And it's pretty thick, so you have to push really hard to get that in somebody. If they are hypoglycemic, you will have a pretty good response of being awakened. They might have some confusion because it takes a little bit longer for the sugar to get to the brain.
Intubated, chest tube, but massive subcutaneous emphysema. Air from the chest is leaking under the skin.
Massive subcutaneous emphysema, subcutaneous under the skin emphysema, we're using that as air. This typically is related to like an air leak or crushed chest where the air is leaking out of. See this sometimes when people have other injuries to their face and air leaks from like your sinuses.
Loosen the pulse.
What do you think?
Tamponade from pneumomediastinum.
Pneumomediastinum is when there's air in the central cavities. Pneumothorax is air around the lung in either side of your chest. But your mediastinum holds your trachea, your esophagus, as well as your heart and the blood vessels there.
About to cut blowhole incisions to release the air.
Do it. Yep.
Usually due to an injury or a tear to the airway, to increase air leaking into that area, you need to get the air out in an emergency situation, so you need it to be released. So that's what they're working on.
Pulse is coming up. Nicely done. Okay, send him to cardiothoracic ICU.
As a doctor, you gotta be cool and calm under pressure. That's why I formulated Chillax by my company Life Happens to help calm panicky feelings and ease racing thoughts and bring on those calm vibes. Find it at lifehappens.com or on Amazon.
Hey, Robbie, we're out of O-neg, but I'm O-neg. Can I donate?
Lori's got more blood flying in.
But I need it now.
O negative blood is the universal donor. AB positive is the universal acceptor. Let me know in the comments what your blood type is. Mine is AB positive. I know. I literally can take anybody's blood. O negative individuals, they could only get O negative blood.
What is our blood status?
Just use the last units of O negative and pause more flying in.
ETA?
Less than 10.
Typically when you give blood, it gets screened for disease processes. Sometimes it gets irradiated. Different processes can be done depending on the individual who needs the blood. She's asking to donate blood. She's giving whole blood at this point. So all of it, your plasma, the white blood cells, the platelets, clotting factors, everything.
Some patients are not going to last that long, and I'm sure there are other O-neg donors that probably work
It
here.
would take hours to screen for HIV and hepatitis.
I have neither, and I donate all the time.
If the patient's gonna die before they get to the OR, then the benefits outweigh the risks.
My man.
There is a risk, infection risk, disease processes, but if the patient's going to die anyway, they want to try everything humanly possible to help. They did a really good job with the medicine, the education, the cases. They're all pretty darn real, and what it looks like, probably the closest I've seen to what I do every single day. If you guys enjoyed this and you want me to do more Pitt Reacts, let me know in the comments. I enjoy this, and as always, definitely binge watch the videos that you see here. And subscribe, turn on your bell notifications, and hit that like button for me. Thank you so much for watching, and stay healthy, my friends.